Really looking forward to discussing some of the new elements of shoulder dystocia with you in this annual update. I think it's really important. I'm just not going to really go into detail, but the idea of a sort of Montgomery consistent discussion of all birth options with women, including the risks and benefits, remains a really primary focus of care. But I think we've got to recognise there's still no clinically accurate predictors of shoulder dystocia, therefore it remains unpredictable and unpreventable, in which case we've got to be ready for it at all births. However, I think there are some new issues that have arisen during the management of shoulder dystocia. I think the first one is it's really important to leave the pool at a pool birth to execute the manoeuvres. We then need to really think about effective execution of those, and that remains key. Don't delay between the manoeuvres. I don't think there's any real benefit to delaying 20 or 30 seconds between manoeuvres. Just try one manoeuvre. If it doesn't work, continue to the next one. There are some novel manoeuvres been described, but some of these can have risks, and I think some of them need more research before we incorporate them into standard practice. And my final thing is, it's really important to consider neonatal volume replacement early, particularly if there's a poor response to initial resuscitation by the neonatologists. We all know shoulder dystocia is most commonly the anterior shoulder impacting on the pubic symphysis, affects between 0.1 and 3% of births and seems to be increasing, and we need to manage it efficiently and effectively with all the multi-professional team to reduce both neonatal hypoxia, which is an increasing problem now, and neonatal injury. Okay, we all know what the risk factors are. However, I think the Montgomery judgment has said to us, look, we just need to we need to discuss and share decision-making with women, personalised care related to a woman's antenatal progress, her history and the clinical features, but also asking the question, okay, what matters most to the woman and her family? And then we can say, look, let's discuss the mode of birth and all the options, including routine care and place of birth, induction of labour, which has benefits and disbenefits, and caesarean section. And those risks and benefits should be discussed for both this pregnancy, but also the consequences possibly for future pregnancies. All that notwithstanding, the shoulder dystocia remains unpredictable and unpreventable. And the majority of cases of shoulder dystocia complicate birth in women with no real risk factors. So therefore we just need to be alert to the possibility of shoulder dystocia at any birth. Now brachial plexus injuries, I always think about 10% of shoulder dystocia get a brachial plexus injury, about 10% of those become permanent. But the good news is, across the UK, permanent brachial plexus injury rates seem to be improving. And I'm absolutely certain this is at least partly related to better training that we've all been undertaking over the last few years. Neonatal fractures, including the humerus and clavicle, are key. Hypoxia and stillbirth are still really important complications. And there's been a couple of papers now in the US saying that, okay, we're better at looking after the baby now with shoulder dystocia, but there are serious risks to the mother still, particularly perineal trauma. A standard recommendation. Let's apply routine traction in line with the axis of the fetal spine and use the idea of diagnostic traction. Is the baby coming? Is it not coming? Do not pull anymore and do not keep pulling except where you're trying to assess whether or not that particular maneuver has been successful. Shoulder dystocia in different birth settings, I think the management is standard across all settings. And if you look at outside obstetric hospital settings, there's a 5-fold increase in neonatal admission after shoulder dystocia. Not compared to all shoulder dystocias, but that's clearly a risk outside obstetric hospital settings. And I think for pool births, as soon as there's a delay with the shoulders, it's really important to ask the woman, help the woman to exit the pool, confirm the shoulder dystocia, so that we can then start the standard release manoeuvres. And I think it's really dangerous, and we should avoid doing any manoeuvres in the pool or standing up or on the edge of the pool, because that's clearly risky for the mother and the baby. The shoulder dystocia algorithm remains fairly consistently the same. call for help, McRoberts, suprapubic pressure, and then either internal rotation or delivery of the posterior arm. So just to emphasize, call for help, declare the emergency, SBAR handover, request a senior midwife, experienced obstetrician, and the additional maternity team. Ask the mother to lie flat, get her buttocks down to the end of the mattress, and allocate a member of the team to support the parents and actually maybe provide a running commentary to explain the actions, which seems to reduce post-traumatic stress afterwards. This will also help with the discussions when you do debrief both the parents afterwards. Now, McRoberts, everyone knows that it's McRoberts push back on the legs. I think it's essential that we use trained professionals. Do not ask the parents or anyone else to join in. Okay, but the key to it is, you've performed McRoberts efficiently when the bottom is lifted off the bed. That's when McRoberts is rotating the pelvis to give you the most space to deliver the baby. Suprapubic pressure, again, from using CPR hands from the side of the baby's back. And all the internal maneuvers is the standard kind of curl your hand up, put it in exactly at 6 o'clock that we've all been doing over the last few years. We've definitely got better at brachial plexus injury, but now we're starting to see starting to have reports of neonatal hypoxic morbidity, and that is absolutely associated with longer durations of the head-body delivery interval. HSIB and NHS Resolution have both published very small case series, but the head-body delivery interval was 7 minutes. The mean head-body delivery interval was 7 minutes, whereas in fact in many published series the maximum has been 6 minutes. And one of the things we think that has been a problem is that people are kind of persisting with manoeuvres even though they haven't worked for too long. And this may increase the head-body delivery interval and the risk of hypoxic injury. Therefore, we recommend try a release manoeuvre. It's either successful or it's not successful. If it's unsuccessful, move on to the next manoeuvre. The neonatal management, there's a couple of things that are really important here. Okay, during the shoulder dystocia, it's quite common that the cord becomes completely compressed. So you get a total cord occlusion. So there's the venous blood is kind of reflecting the mother's side rather than the fetal side, and that can be falsely reassuring. So you can get apparently normal gases with a baby in very poor condition. So don't be reassured by that. That's probably due to the cord compression. Now, equally, that cord compression can cause hypovolemia in the baby, so that the vein is compressed, but the arteries are still continue to be pumping blood back towards the placenta, so the baby can be more hypovolemic. And I think if the pediatricians or neonatologists are struggling with resuscitation, worth suggesting that it may be worth some kind of volume replacement. Now, the other actions are as per the new RCOG Green Top guidelines coming out in hopefully this year. Document the shoulder dystocia, and I think if you have a look at many of these small series, then everyone has observed that documentation seems to be improved using proformas. Now, there are some manoeuvres currently outside UK national guidance, and digital axillary traction in a sort of what's been described as a sort of trigger idea of your finger underneath the posterior axilla, and very positive results been described by Leslie Ansell's group in New Zealand, but they do describe a theoretical risk of increased inhumeral fractures. What we're suggesting at the moment is pragmatic to focus on the standard release maneuvers that we have been learning in the last few years, which have proven to be effective. And so therefore, it's not currently in UK guidance, but I think there's a possibility to consider using digital axillary traction where other maneuvers have been unsuccessful. Now, axillary traction of the posterior arm using slings or neonatal feeding tube, I think they have been used in a small number of cases, but there have been at least one very serious neonatal complication where the fetal arm was lacerated by the neonatal feeding tube. And I think be very careful. And at the moment, this should be avoided. Effective training in shoulder dystocia, as we know, most current national guidelines recommend the same maneuvers in the same order. And actually, there have been really reassuring, excellent publications demonstrating reductions in brachial plexus injury post-training from the UK, the US, New Zealand, and Sweden. And the current evidence suggests that effective training is still local, annual, multi-professional, where the release maneuvers are practiced on a proper mannequin using the RCOG algorithms rather than any kind of mnemonics. So the key messages from this talk are: shoulder dystocia is an increasing problem, but brachial plexus injury need not be. We need to employ the standard release maneuvers outlined in the current national guidance in all birth settings. Don't try the maneuvers for too long. If it's not working, move straight to the next maneuver. Alert the neonatologist to the possibility of hypovolemia if the baby requires resuscitation. And effective training should be made available to all of us working in maternity. We put up a standard picture of the algorithm with pictures, as some people find that much more accessible. Thank you very much.